All right, we'll go ahead and get started. So welcome everyone. My name is Mina Nabavi, and I'm a program director with the University of Alabama at Birmingham School of Public Health's Office of Public Health Practice. I'm excited to welcome you to today's webinar, The Surge of Congenital Syphilis in Alabama, Exploring Reasons and Prevention Strategies, featuring Dr. Agnes Oberkor, Congenital Syphilis Coordinator, Clinical Consultant for Sexually Transmitted Infections, and lead trainer of the Alabama Department of Public Health Sexually Transmitted Disease Control and Prevention. This webinar is made possible by the Alabama Regional Center for Infection Prevention and Control, or ARC-IPC. The ARC-IPC was established to meet the consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreaks Division and the University of Alabama at Birmingham. The ARC-IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to detect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, view and listen to past trainings, webinars, and podcasts, request training and technical assistance, sign up for our newsletter, and view infection prevention and control resources at the website listed on the slide. You can also email arcipc@uab.edu with any questions. We would like to thank our co-sponsors for today's webinar, the Deep South Center for Occupational Health and Safety, the Alabama Statewide Area Health Education Centers, and the Alabama Public Health Training Network at the Alabama Department of Public Health, part of the Region 4 Public Health Training Center. You can learn more about their programs and these centers as a whole at the websites listed on this screen. We'd also like to let you know about our next upcoming webinar with AC Burke from RB Partners. AC will be speaking about mitigating the spread of respiratory illness in long-term care facilities. It's respiratory season, and in addition to hand hygiene and respiratory etiquette, what else can we do to help protect our residents from respiratory illness? This webinar will describe 10 strategies for mitigating the spread of respiratory illness. The discussion will include information on air management and strategies for improving ventilation in long-term care facilities for helping to prevent the spread of respiratory pathogens. This webinar is presented by the Alabama Regional Center for Infection Prevention and Control and is co-sponsored by the Deep South Center for Occupational Health and Safety, the Alabama Long-Term Care Strike Team, and the Alabama Statewide Area Health Education Centers. It will be held on January 21st at 12 p.m. Central Standard Time. Continuing education credits have been approved for nurses by the Deep South Center for Occupational Health and Safety for this program. In order to receive credit for this training, you must register for the training, watch the entire program, and complete the evaluation following the program. Upon completion of the evaluation, you will be redirected to the Alabama Nursing CEU request form, which you will also need to complete. CEUs will be awarded by the Deep South Center for Occupational Health and Safety. CE units for this program will expire December 4th, 2025. If you experience any issues, please email arcipc@uab.edu. We'll also place this email in the chat box. And finally, it's my pleasure to introduce our speaker. Dr. Agnes Oberkor is the Congenital Syphilis Coordinator, Clinical Consultant for Sexually Transmitted Infections, and the lead trainer of the Alabama Department of Public Health Sexually Transmitted Disease Control and Prevention. She is a board-certified registered nurse practitioner and a registered nurse. Dr. Oberkor's primary interests are program improvement, training clinical staff in STD patient management, and writing clinical protocols. She is particularly interested in methods for understanding healthcare providers' knowledge in STD prevention, especially syphilis in pregnant women and congenital syphilis. Dr. Oberkor holds a BSN from Auburn University, Montgomery, an MSN and an MPH from the University of Alabama at Birmingham, and a DRPH in Health Advocacy and Leadership from Capella University. Her research was on quality improvement in public health programs. She coordinated the expedited partner therapy policy and got approval for ADPH clinicians in 2014 and for all healthcare providers in 2024. Dr. Oberkor received the NCSD Public Health Policy Academy training in 2016. And so without further ado, it is my pleasure to turn things over to Dr. Oberkor.
Thank you so much, and I appreciate the invitation to be part of the program today. It's such a pleasure. So for objectives today, we'd like to identify various missed opportunities for congenital syphilis prevention in Alabama. I want you all to understand we're talking about Alabama today. Although congenital syphilis is a nationwide issue, but let's look at where we are in Alabama. And then we'd like to, by the end of it, I'd like to establish prenatal syphilis testing and adequate treatment for syphilis in pregnant women and their partners as a standard of care. If it becomes a standard of care, we all will be aware of it and be conscious of preventing it. And then I also want you to collaborate with the Alabama Department of Public Health to enforce congenital syphilis prevention in Alabama. So just a little bit overview of congenital syphilis, syphilis. It's a systemic infection, and it's caused by the bacterium, spirochete bacterium called Treponema pallidum. The incubation period for syphilis typically about 10 to 90 days. It just depends on the individual and when they show clinical presentations or clinical findings in those patients when they come to us. It's a curable infection, so that's a good thing about that. Looking at transmission mode, it's sexually via skin and the mucous membrane during early stages of the disease. That's a primary or secondary syphilis. Those are the two stages that is considered most contagious. For pregnant women, this can be maternal transfer and is via the placenta. So for vertical transmission, that's from via the placenta, it can occur during any stage of syphilis. Okay? Syphilis has stages. It progresses through stages. So the stages we have primary syphilis, that is where the Treponema pallidum got on the person, the site of inoculation, that's where the bacteria will go into. And so at the site, we see clinical manifestation that show like a sore, or lesion, typically a sore, and the sore is mostly painless. Then it will transition to secondary syphilis if it's not treated. And then again, if it's not treated, it goes to latent syphilis stage. Latent syphilis means no signs and symptoms, that's latent. And then untreated, it goes to tertiary stage, or it can resolve with treatment. There are major complications with syphilis if it's not treated. Neurosyphilis, that's affecting the central nervous system. And then we have ocular syphilis affecting the eyes, and the autosyphilis, that's the ear. Now, these complications can occur at any stage of syphilis. Looking at treatment of syphilis, it's treatable. I said it's a curable disease. The recommended treatment for syphilis is the benzathine penicillin, and it should be treated, the dosage will be based on the stage of the disease. For pregnant women, the only recommended treatment for syphilis is the penicillin. So if they are allergic to penicillin, they have true penicillin allergy, we have to refer them to the hospital to have a desensitization done and treated with penicillin. So adequate treatment is based on the stage. Like I said, it's very, very important. And so also based on the dosing. So we have penicillin, but we have to know what stage the patient is in order to give the adequate treatment to this patient. And we can understand when you're talking about congenital syphilis, if the treatment is not adequate, the baby will get infected. Okay, so that is one of the biggest problems we have in Alabama. So untreated or inadequately treated person with a Treponema pallidum remains chronically infected and can develop significant clinical manifestation or complication, as I said. Also, untreated or inadequately treatment in pregnant women can lead to fetal demise, serious congenital infections of the neonate. So prevention of congenital syphilis is mainly early detection and adequate treatment of the pregnant women. And that is our goal here, to make sure that pregnant women, if they're infected, is detected as soon as possible, and they are treated to save the baby. So we want to talk about now, so why, if this is simple, why are we having problem with congenital syphilis? Okay. So when I took over this congenital syphilis, it was in 2006 when I started being the coordinator of this program, and I have no data back there, so I started data, and for 2026, we had 11 cases in Alabama. And then 2027, we had 10. It kind of went down a little bit, but we went up to in 2008. That is when we started looking at it, something need to be done. Those days, Alabama, we ranked like maybe 3 in the nation, 4 in the nation, 5. It's still high for Alabama to be on the list like that. So we started looking at what to do and what would be the problem, what is driving it up. And what we established or we found out was that it was due to lack of established prenatal care screening. So it's not established, it's just there, everybody's doing what they want to, providers, they may follow the CDC guidelines, but sometimes they are not clear on what exactly to do for their state. And as you know, in public health, we have the CDC guidelines, but we also have to think about our jurisdiction to make sure that whatever is going, we manage what is going on in that area. Okay. So that's why we really lack of established prenatal care. So we have to establish one. That was our prevention strategy number 1 for the rise between 2006 and 2008. And so we established that, and it gave a clear screening guidelines for providers. We also added that there should be a screening at the first trimester of pregnancy or at the first visit, and also at the 3rd trimester, preferably between 28 and 32 weeks of gestation, where with the highest risk specified, like for risk factors in pregnant women, like a pregnant woman with multiple sex partners, new partner, have other STDs, we consider those high risk, or those who have drug use, or they exchange money for sex. So those are the women we targeted from the beginning, and so we added that risk factor. And so we also included that prompt treatment based on the stage of syphilis is very, very critical to prevent congenital syphilis. And then we added partner management. Okay? So the partners can be managed. And this is just in addition to the write-up in the state law, this is a simple form that we had in guidance for the providers. And so we also included chlamydia and gonorrhea, because we are thinking about screening sexually transmitted diseases in pregnant women, not just to isolate syphilis. So additional strategies we added was a prenatal care provider visit by a disease intervention specialist staff. They're specialized staff, very qualified in interviewing patients, visiting, and extracting information we need to help treat the patient and the partners. They are very, very good at following partners to get them so we can get them treated. So what they did, they will discuss disease, the diagnosis with the providers. They will also discuss treatment during pregnancy, and they will discuss congenital syphilis prevention when they do their visit. We also did provider education package, and we sent it with the providers, with the disease intervention specialists. So this include about syphilis prevention, taking sexual history, and also the CDC treatment guidelines. And I said all the time, if you never heard me, I would say that in Alabama, STDs are airborne, they're not by sexual transmitted, because nobody wants to talk about sexual transmitted diseases. So that's something that is kind of limiting when it comes to prevention, when the providers are very reluctant or don't want to talk about sexual issues. And so we also provided technical assistance, and when we visit them, and they can also request for more information. They can request for treatment, and we do typically provide free treatment when they need help and free testing. So what is the outcome of what we did? That's a public health. What we did, our strategies of intervention, what did we gain out of it? Was it helpful? So let's see how it is. That's how we turn out the trend after we implemented the new screening, or let me say the guidance for the providers. We saw that and we rolled it out in 2009, but we had only one case decrease. 2010, it was good. We went down. And then 2011, we just picked up one. And then after that, we started going down gradually, which was very, very good. And we went on implementing until in 2014, something changed. The rules we had was repealed and was replaced. And don't ask me because I don't know why. It was replaced with a blanket statement that said testing of pregnant women for sexually transmitted diseases. Practitioners of pregnant women shall follow guidelines set forth by the American College of Obstetricians and Gynecologists, that's ACOG, for testing pregnant women for sexually transmitted diseases. Now, if you know about ACOG, it's a paid organization. I'm not a member, so I don't really know what is there. Sometimes I get information, but most providers do not have access to ACOG platform. So I believe it was an issue. And we implemented this guidance between 2015 and 2023. And so let's see the outcome, why we're looking at the surge today. So we left from 2014, that was 2, and then 3 in 2015, and we started picking up in 2016. Down in 2017, we went up, 2008, 18, and we've been going up since. So that was the change. And somebody will say, well, there was a rise everywhere in the nation. Yeah, it's true, but we had something that was working. And then all of a sudden we change. And once you change something and it takes effect, it's hard to turn the wheel. It starts to turn around and go a different direction. So that's how we've been having. And we have to find out again, what is the problem? We can't just say it's going up because of the guidance change. So we have to find out what is exactly going on. How can we go back again and help? So we started looking for missed opportunities that is creating the surge in Alabama. And this slide will explain what is going on. We can see the blue one line is late identification. And what that means was that these are women who actually sought prenatal care at least 3 times during their pregnancy. Their first syphilis test was negative, but no other testing until delivery. And so when they show up at delivery, they have syphilis. So those are the late identification cases. They did go to their doctor. They had a screening done, but the first one negative, subsequently no testing until labor and delivery. Okay. The red line here is no prenatal care. And as you can see, it fluctuated from 3 to 5 to 4 to 5. It is no prenatal care. Those people, I say, if we cannot take care of the ones that are already receiving prenatal care, what can we do to the ones that never went to care? So that is something that I would say, until we are able to stop late identification, it's hard to go back and tackle those who are not receiving prenatal care at all. The next one is inadequate treatment. Also, it's the provider, because it's provider who's treating the patients. So if there's no, I said earlier, inadequate treatment just means never even treated, because the treatment will not work to kill those bacteria. The next one is unidentified missed opportunity, another headache. Unidentified means the pregnant woman had syphilis in the past and treated adequately, but they had a baby and now the baby has syphilis. So the question is, what is the problem? Is it a treatment? Did they get reinfected, or what is the problem here? So we have to find out what is going on with this number, and a significant number of them. So we have to look at it. The next one, late prenatal care, which is just about no prenatal care patient. And the last one is in the orange is no syphilis test. Again, that's a provider issue. That we have women who actually sought care, they've been through prenatal care, no tests for syphilis at all. And I'll say last year we had a fetal death out of that. The lady actually said, I told the doctor, my partner said they had syphilis. But the doctor said, you'll be fine. So the baby died at 36 weeks. Okay. So these are the issues that we had in Alabama. And now we have to think about what can we do about that. Not just that, so as I begin to look and dig in for what is the problem, I realized that let me check insurance coverage. And it shows, I can see that about 95% of our cases in Alabama are Medicare recipients. If you don't know the problem, you can resolve, you can find intervention. So that is what my findings were, and we did something about that. So Blue Cross Blue Shield just won. The uninsured people, they don't have insurance at all. For 2021, it was 2 of them. And then in 2023, it became 5. So we kind of have been picking up those numbers also. TRICARE won, and for unknown, that means after reviewing the record, I didn't find any kind of health insurance for those women. And there were about 1 in 2021, 8 in 2022, and then 5 in 23. So that's significant. So as public health professionals, we're looking at with a significant number. So what can we do with Alabama Medicaid to help us resolve this issue? And I'll tell you soon. Now, this one is, we're looking at the rate because we have to look at the numbers, we do rate, and also look at the impact in Alabama. We had syphilitis stillbirth in the one in the orange is the rate, but the yellow is the syphilitis stillbirth. That means the baby died before delivery. And we have infant death. Infant deaths are the babies were delivered alive and then they died later on. So you can see we have those last year. We have 2 syphilitis stillbirth, no infant death. But we have to look at how we can prevent the increased numbers of cases. One baby dying is just too many to me. With all the healthcare system and everything we have in the United States, just one infant death or one congenital syphilis case is too many. I've worked in tropical areas, undeveloped countries, and if they have this kind of healthcare that we have here, I don't think they will have any congenital syphilis cases out there. We can't look at cases without looking at the population that we're dealing with. So we can see here that the white population, a little bit lower, the Black population have the burden of the disease more than any of the races. So as you can see, about almost 60% of the cases are from the Black population. So the question I had most of the time was that, so is it just one section of Alabama that we're having problems or everywhere? And I can say everywhere because you can see here, we have the northern district, the northern part of the state. And I just have this for 2023 because I started collecting it just last year. So you can see we have 7. And it's just the pattern, for the previous years. I just didn't have the data here for you, but it's higher in certain areas. Of course, in west central area, and I think that's the Tuscaloosa area in that region, we have the highest, and then by the northern, and then followed by Jefferson and East Central. So you can see it's everywhere. So when we have to know this, so when we are trying to create intervention, we know where to go. So I talked about the cases of unidentified missed opportunities. Those are really very concerning to me because the mother has to receive treatment. So I will show you some of this. And just to begin with, when we talk about surveillance case definition, it's just reporting to CDC, and also we're looking at clinical, okay? So typically, according to CDC guidelines, there's certain criteria that would trigger evaluation of the infant for evaluation. So most of the time, we don't have a consistent information to evaluate this patient. Okay? So what I did, I started collecting their medical information, and I'm trying to get there so you understand. If you can see this slide, I started looking at individual cases of these, some of them, of what happened. And if we look at this patient, and then number one here, she was infected in 2017. That was in November. Okay. She received treatment. And if you look at the treatment here, at the time she was not pregnant. So the treatment was adequate. Okay. And at the time of delivery, her titer, what we call the non-Treponema titer, went all the way down to 8, and it's way down fourfold. We're looking at fourfold decrease to determine treatment adequacy. Okay. But in this case, very adequate. I mean, nothing will happen. Actually, most pediatricians will not screen a baby like this. But we have some few pediatricians in the state, which I'm really thankful for, that will screen infants regardless if their mother had history. And we have just a few pediatricians who are still doing that. And this baby, for instance, had a long bone issue, abnormal long bone X-ray that was consistent with congenital syphilis. Now that is serious to me. Somebody who was treated 2 years before she became pregnant, and the baby had syphilis. Baby had no signs and symptoms. So like I said, this baby would have missed any evaluation if it's not because of this pediatrician. If you look at the second one, it's just about the same. But this time they did a lumbar puncture to look at a CSF analysis. And he had the WBC analysis were higher, and the TPP was reactive. The baby has syphilis. The one, I won't go through everything, but there's one that's very interesting to me that I wanted to see the last one here. I just wanted to see if it's what I was thinking was correct, that mothers treated for syphilis with history may have babies that will have congenital syphilis. And I think we discussed this with CDC team came over, and we talk about these issues here. I'm sure they are working on it to see what, maybe do a further research to see what is going on. But this baby was released and discharged from the hospital, and the disease intervention specialist called me because she knew what I was looking for. And she said, this baby is going home today. What do you think? And I said, no, tell them to take the baby back and do a lumbar puncture. Do an X-ray, long bone X-ray, and do a lumbar puncture. So they did, and I could see the documentation in the medical record. I like a little bit scary, like to put my name all over there. I'm like, if this lumbar puncture didn't go well, I'd probably go to prison on that. So, but this is what happened. This mother was treated in 2020, December 2020, where she had a baby 2 years later. That means she was treated before she became pregnant. And if you can look at the titer here, she had a good response to treatment. Her RPR was 1 at the time of delivery. The baby had no signs and symptoms. She was treated adequately. But the baby had a titer that's a little higher than the mother, a 2, and the mother had 1. So I said, let's do a lumbar puncture, see if what I'm thinking is just not right. I'm just overdoing stuff. And lo and behold, the lumbar puncture was abnormal. This was a non-traumatic lumbar puncture. Everything went well. So the baby has a very high cerebrospinal fluid, protein, and WBC, which according to CDC is considered a case. Okay. So I'm sharing this for you to know there's more to what we are doing here, trying to figure out what the problems are. Because most people or most states will not go and look at all this nitty-gritty things to figure out how we can intervene to help reduce the surge in Alabama. And so just happy to tell you that this year, April, the governor approved the rules we had before in 2008. So now we had it back to implement again. So just to say we saw the surge. So we're thinking, my thinking is that we have to go back to structured screening, give the providers some kind of structure to help them to screen pregnant women. And so this is the rule. It's just about the same. What we didn't add here is a risk factor. We just open it up. Every mother is a routine screening now. It's not based on risk factor during the early third trimester screening. So now we're screening every mother at the first prenatal visit. And then at 28 to 32 weeks pregnant, they have to get screening, routine, no risk factor, regardless of risk factor, and then at delivery. So now we have consistent way of looking at what is going on. We're hoping that all providers will adopt this screening. We just had a case that was airlifted to UAB, baby. The mother has syphilis, untreated, at delivery. The baby had no reactive syphilis test. So the baby was not treated. And a month later, the baby has serious complications and ended up with a UAB with all even put a ventilator and all the stuff on. So we have to do more thorough education and guidance for these providers. So now we're taking care of the screening and routine repeat treatment. So remember, I just talked about the cases that are concerning to us, the mothers that receive adequate treatment before and their titer was 4-4 decrease away before they became pregnant. What can we do for such people? Now we're doing this. We did a screening back. Now those mothers, what we are doing is we are repeating the treatment of syphilis when they get pregnant, regardless of their titer level. And we've been doing that for a little under a year now. We're almost going to a year. And so I will give you feedback on whether this is working or not, whether we are able to identify what to do to prevent those cases from going up. And also routine screening of all babies with maternal history. So it's not just those few pediatricians who want to screen babies whose parent had syphilis, but all babies. We will share data with the providers, and we educate providers and visit those who reported cases. So collaboration, what do we about the healthcare provider issue that we picked up? There about almost 95% of the cases were Medicaid recipient. What we share data with the Medicaid, Alabama Medicaid, and they were very helpful. So in 2022, we did the Health Alert Network together. You know, we do as a joint message out to providers. And the providers' complaint was that they would not be reimbursed if they screen. And so now Medicaid will reimburse everybody who's in. They said, regardless of the number of times you screen, we will pay. So that's very good that Alabama Medicaid is responding very positively to this to bring the disease down. Also, Alabama Medicaid funded, so from this year, they are funding the infant follow-up. So those babies who have syphilis, congenital syphilis, they are funding it. So we have case workers who follow up on these babies and make sure that they go to see their pediatricians and get screening and treatment if needed. So that's very, very helpful. And also we are doing Alabama Coordinated Health Network is also on the Medicaid, and we do the training with them. So when they visit their patient or do the case management from Medicaid some point, they will touch on prevention, congenital syphilis prevention. We also have out-of-state public health initiatives that we join with other people. We just did one with North Carolina, South Carolina, and all those southern region, southern states that we did the meeting and we discussed how to get Medicaid. But then we already worked something out with Medicaid. So we have something going already. So it wasn't new for us. We just have to reinforce what we are doing for the state. There are other activities that we're engaged in. I talked about it, the Health Alert Network, that's HUN, and that goes out with every update. I just send one out just to let them know where we are and what we need to done, and also to let them know that screening is now, it should be a standard of care in every practice in Alabama. We are continuing to do provider visit and education. We have involved NPH and DNP students, and I'm happy to say we had one from UAB student that helped us with some of our flyers, and I will get to that so you can see that. We provide technical assistance, especially for staging, because adequate treatment is based on staging. You'd be surprised that sometimes they call and say, we treated a patient. I said, what stage did you treat? Stage? See, they come out like, just treat it. So we have to guide them as to what staging it, how to stage it, so we can have adequate treatment for everyone, especially pregnant women. We also send messages. We did some flyers and some ads to target mothers who are not insured. So there's a program for like insurance in Alabama that they can get qualified. We do that. We also have free at-home STD testing to increase testing access. If they can come to the health department and they have their little phones, at least everybody has a phone with the internet on it, they can order the lab kit from our website, and it will be delivered to them. They just have to do the specimen, collect the specimen, and mail it back to where they receive it from and get a screen, and we provide free treatment. If they cannot go to the health department for treatment, we call in for them prescription so they can get treatment, and as well as the partners. Free partner testing and treatment. We also participate in Alabama, Mississippi ACAL conference. It happens every year in May in Florida. And so I attend that, always attend that to make sure I share information with them. I said earlier, we did a podcast, which we're supposed to be continuing to do with Dr. Hyde at UAB. We have paid advertising, targeting not just the pregnant women. My main target is providers and expecting fathers. So not just the mother, and as you can see, the late identification, the mother went to the doctor, as we said, is the doctor who dropped the ball. So we are targeting the doctors now and then the fathers, so they can also be responsible for preventing congenital syphilis. We do Facebook, TikTok, targeted emailing, and geofencing. Those are some of the advertising we do. Sometimes you can see billboards, or you can see those TVs at the gas stations. We sponsor those as well. So this beautiful flyer was made by one of the UAB students, and Matt Havin did, okay, sorry. She did that for us in 2022, and we've been using it. I don't want to let it go, although I've done a new one, I still use it because she puts so much effort in it. And so just want to let you know, I appreciate the students at UAB, very helpful. These are just other flyers we have. We have some of them on big screens at the health department. It's just like a stand, so patients will see it. Everyone will see it and prevent it. These goes to patients as well, targeting, and you can see we say, syphilis, HIV prevention, pregnant women. We make it simple so they know exactly when to start prenatal care. We say first test at 3 months. So it's like we are actually advising them 3 months, you have to get your prenatal care. And 7 months, 8 to 8 months, get another testing. So this time they can request from the provider if the provider is not taking the initiative to do the screening. Similar thing. So look at this. I said, protect your baby. You see the both, man and woman. And this is the lady here, but we have one that I like that says, protect her baby. So this one targeting providers, partners, again, like I said, we want to target everybody to get involved. I talk about health insurance, and so this is a flyer that was sent out. And I can tell you when it comes to health insurance, those who are self-paid, pregnant women are mostly in the north, like at the northwestern part of the state. Those are the areas that we find more self-paid pregnant women. And it's not good because those are the ones that typically will have very serious complications of the woman because they don't have any care. So we have a few limitations on what we found because there's inconsistent evaluation of infants with maternal treatment history. It's not every, like I said, not every provider or pediatrician who will actually screen the babies. And these findings may be just typical to Alabama. Other states may have different things, so we just keep it to Alabama, and that's why I'm speaking to Alabama providers. Challenges are pregnant women with substance abuse issues. And some of the issues are that even when the DIS go out to look for them, they will refuse to come for treatment. We have some that after the DIS will work on her in Mobile, many times she came to the clinic, sat down for a few minutes, walked out again. So those are our bigger challenges. And also for pregnant women with no prenatal care because of no health insurance. So those we are targeting, trying to get them involved. And we're also working with Medicaid to see, can you do something about the eligibility criteria for people who are pregnant, at least during the pregnancy time, so they can get care. And then our also challenge is true penicillin allergy. If they're really allergic to penicillin, they have to be desensitized. And the question is that, how can you put them in the hospital for 10 to 14 days for them to get a treatment? Some of them will say, I have little children, I can go. Some will say, I have to go to work, I can be in hospital for such days. So that's our challenges when it comes to treatment for those who are allergic to penicillin. Recommendations, our recommendation of public health leadership over STI screening in pregnant women. It shouldn't be taken from public health and given to an entity or society or something like association, something like the ACOG. It should be under public health so we can evaluate what is going on. We can give a suggestion that we can make changes if needed. We also want to make sure that congenital syphilis prevention strategies are part of the standard of care. Like wherever you go, it's part of the things you need to do as a provider to prevent congenital syphilis. And also a standardized method of evaluating infants who mother has a history of syphilis. We don't have a standardized evaluation method. So we're having just few providers who do that. And also special Medicaid eligibility. I talked about that for pregnant women, so everyone can get screening. So is it possible to stop congenital syphilis surge in Alabama? I believe it's possible if we all join together. And looking at the whole picture that I started from the beginning, where we were, what we did to make it go down a little bit, and what we did again to begin to see the surge again. So it's doable.
Thank you so much, Dr. Oberkor. This has been a wonderful overview of congenital syphilis in the state of Alabama. I would encourage our participants, please feel free to drop your questions in the Q&A box. I have a couple, but we do have about 10 minutes, so I'll get to as many as I can. So the first one came, and it came in on Dr. Oberkor when you were talking about collaborations. The participant is asking, doesn't the PCN injection raise possibility of premature contractions?
So, okay, thank you. So far, we have not seen that. CDC has done research to give us the recommended treatment, and we have not seen one so far. I have not seen it in the treatment guidelines, and I have not observed one in our clinics so far. I would say if it's there, maybe the person never complained to us or will never call back, but so far it's been good. If you know of any case, I would like to know so I can personally investigate that one. Thank you.
All right. This question came in around when you were looking at kind of congenital syphilis cases across the state. This attendee wanted to know, what impact does access to healthcare in rural versus urban areas have on the prevalence of congenital syphilis? So I know you showed there are cases all over the state, but are you seeing any difference in more rural areas?
Not rural areas though. It's there's no impact. I haven't seen any impact. We're talking about rural or urban areas, but I would say if they're in an area that no work, maybe that's why they don't have insurance. No, uh, what we're considering if they don't have access to testing, we have made a website available that they can order a kit so they can screen themselves. And we send our advertising to just about every area. And when we talk about rural areas, we're sending it geofencing, uh, email targeting, certain areas like drug centers, like a Walmart or any little store that can be in any area that people go. We are sending information there. So again, I have not picked up on specifically rural areas having access issue to testing. And again, we have the health department in every county. Every county in Alabama, we have clinics there. So let me say, do we ask them, this pregnant woman, why they didn't receive prenatal care? Some of them would do. Some of them would not respond at all. What I know is a problem in the rural areas is drug use. Okay, drug use is a problem in some of these rural areas, and that's our problem. Okay, another area that we have problem, I don't know what is a rural, but you have the states that are bordered by the other neighboring states. Okay, I don't know whether because they don't have access, the neighboring states come a little bit closer to them maybe, and they want to go there rather than coming to Alabama. So I will look into that, but I do not have a data or a very good information to say we have problems with access to care in the rural areas. I will look into that again. I will. Thank you.
We had another question come in with the penicillin G shortages. Do you feel alternative treatments like antibiotics like doxycycline will be as effective to prevent congenital syphilis?
Yeah, for pregnant women, we cannot use any alternative. It has to be penicillin. And it's good, but we are good in Alabama. We have penicillin that we can provide. And when the providers do not have it, we try to arrange, okay? So the patients can come to us for treatment at least. For the hospitals, we have not received any information from a hospital that will refer them to that would say they don't have penicillin. But the alternative to penicillin is extensiline that CDC said we can use. We are ready if we need to get extensiline to use, we can have some. But so far in Alabama, we have not seen any shortage of penicillin so far.
Perfect. A more general question, what do you think the recommendations from the incoming administration will have on congenital syphilis, kind of looking ahead?
Incoming administration, you're talking about from federal level?
That's what I would
Okay.
guess
So
from this
I
question.
don't think it would be an issue. I don't think, because what we are recommending is nothing strange. It's just something that has to be part of the care of the patient. So I think it will be, they will receive it. I don't think we will have any, I do not anticipate any problem, honestly. Yeah. But if we do, we'll just go around to do what we need to do. Because we're in Alabama, we want to take care of our people. So if there will be a problem, I mean, we can talk to our representatives from Alabama to reconsider whatever they would do. But again, I do not anticipate any problem. But if we do, we have other ways to get around and get things done.
One participant is asking, do you think, or did the COVID-19 pandemic play a role in the spike in syphilis infections?
Yeah, that's very interesting. Actually, if I asked questions during COVID-19. So for 2020 data, 2022 data, I actually asked patient, do you think COVID has a problem? You know, the reason I only have one case, only one case that admitted that yes, COVID was a problem, that she was scared to go to the doctor.
Mm.
So, but after that, I think I've asked those questions 2020, I asked in 2022. 2023, I did not ask because I didn't get any good number for me to keep doing it. So I didn't ask for 2023, but certainly 2022, 2020, 21, 22, I did ask those questions and received one question, one impact.
One more question just came in. Person is saying pregnant women do not have the extra 2-day grace period for receiving doses 2 and 3 of Bicillin. Does recent data show that that 2-day grace period increases the risk of failed treatment?
Yes, that's from the CDC recommendation. Okay. And what we have here in Alabama is that because our clinics closes on holidays and weekends, the recommendation to the clinicians was that when you give somebody penicillin, especially pregnant women, give them the next appointment considering holidays and weekends. And so we can give them 5 days, up to 5 days between treatments so they don't miss. So like we just had this Thanksgiving pass, and we had to treat somebody on a Wednesday to make 5 days, so we don't have to skip because of Thanksgiving holiday. So we do that. When you go over, according to CDC, the treatment becomes ineffective because it's not going, the baby, we're considering the baby, transmitting it through the placenta to the baby. So we don't want to delay the treatment. This is a CDC recommendation. We don't want to go over it. I know some providers do 9 days, up to 9 days. But in Alabama, we recommend 7 days or we'll start all over. And especially seeing what we are, the concern cases that I talked about, especially with those cases, I'm very, very strict on the treatment interval because we don't want to go beyond, because I don't think I have the resources to begin to research the 2 days extra, what will happen if we miss it. So far, we are keeping that, but to relieve the problem, we will consider the next treatment appointment date to make sure that if the patient cannot come on the 7th day, or we're having a holiday or weekend coming up, we can do 5 days in between instead of the 7 days, just to solve the problem. Yeah. And there's something I didn't say in the previous question. We cannot use doxycycline in pregnant women because we don't use doxycycline in children. So doxycycline is not allowed to be used during pregnancy. So that's why we cannot use doxycycline or tetracycline during pregnancy.
Perfect. Well, that's all the questions that I see that have come through, and we're at the top of the hour. So, Dr. Oberkor, I want to thank you again for this very informative webinar. We appreciate you taking the time out of your schedule to share this with us. And again, we hope to all see those number of cases start to decrease in the next few years. So we appreciate all of the work that you are doing. And for our attendees, thank you so much for joining. Again, there are no other webinars for 2024, but we do look forward to seeing you back on January 21st, 2025 for our webinar on mitigating the spread of respiratory illnesses in long-term care facilities. Thank you so much.
Thank you. Thank you for the time and the opportunity.
Yes, bye-bye.